Thank you very much, and thank you to Oxford Nanopore for inviting me to give this talk. So I'm going to talk to you about metagenomics, which, if you remember, is the detection of all nucleic acids from a clinical sample for the identification of infection of unknown etiology. And it tends to use a single sample, it's unbiased, and it's all-encompassing. So I'm going to tell you two stories. The first one is about our participation in this national study that was actually developed by Guy's and St Thomas's Hospital, using actually a metagenomics pipeline for both RNA and DNA. It's funded by NHS England. It started in the winter of 2024-25. And it's aiming to provide rapid respiratory metagenomics in ICU patients with a turnaround of 9 to 24 hours, so reporting the same day and the next morning. Unified for all infections. It uses untargeted ONT with a depletion methodology, and the aim is to inform patient management and pandemic preparedness. So we adopted this method. It was transferred to us to try in the beginning of winter 24. We are a different hospital from Guy's and St Thomas's. We're a tertiary referral paediatric hospital, and about 30 to 40% of our patients are highly immunocompromised. Our samples were different, slightly different. We had more upper respiratory samples, and many more of our samples as a result were polymicrobial. We focused on the paediatric and cardiac intensive care units and the ECMO unit. And we changed the reporting of the pipeline to reflect our microbial practice at GOSH. And we reported bacteria even if the reads were, where there was more than 10 reads, even if the abundance was less than 1%. And we also reported any pathogenic organisms. So this was where the sensitivity and specificity reporting was benchmarked. We validated all results against culture and or PCR, and we included PCRs sometimes for organisms that we wouldn't normally look for by PCR. And we processed 177 samples in 3 months with the same turnaround that was specified by Guy's and St Thomas's. So here are the results. You don't need to look at these very closely, but I've compared the GOSH results to the Guy's and St Thomas's results, and I just want to point out that we had a very, very similar output. It was an amazingly robust protocol. We had very high specificity, very few false positives. At the same day testing, we managed to get most of the bacteria and quite a high proportion of the viruses and fungi reported, and by the final report, those numbers had gone right up. We missed a few very low positives, but don't forget we were reporting much lower positives than most people would normally. And just to focus on the method of confirming, you can see that the bacteria was mostly confirmed by the bacteria was mostly confirmed by routine methods, and so were the viruses. We did do some additional PCRs to confirm some results for all of the different kingdoms, and we had a few false negatives. So what was the impact of this? Well, we've done a preliminary analysis. You can imagine this is only fairly fresh data, but the impact was already discernible in very much the same way as Anna reported. If you look at clinical care, there was a change in clinical care in actually, I think, more than 40% I think these numbers have changed and become even more impressive. More than 40% of the clinical care was changed by the result. And for the most part, that was either stopping antibiotics, as you can see, again, a huge number was stopped, and starting new antibiotics, and even the confidence to continue antibiotics that had been started as an empirical approach. Moreover, the acceptability, and this work was led by Robbie Hammond, the acceptability was very high. You can see that of the nurses and medics surveyed, over 70% felt this was a positive impact, and this was just 3 months. So we're not new to metagenomics. We have been running a metagenomic service at GOSH since 2014, and it was accredited, UKAS 15189, accredited in 2024. But the indications for our service are different. We use it for encephalitis, tissue and sterile fluid. It's a last resort metagenomic service. So these patients will have had very many tests done beforehand, and the metagenomics comes to us to say, what could it be? So the importance of our service is to detect and to exclude infection, because we're often, on the basis of our results, advising people advising the clinical team that they can then start a very strong immunosuppressive therapy. It's Illumina-based, and it takes 5 days or more to run, which is very different from the Nanopore based respiratory metagenomics. It is more sensitive. We're getting down to very low copy number for RNA and DNA viruses and pathogens in sterile fluids. It is less sensitive in tissue, however. It's a little bit less sensitive for DNA, although RNA is pretty sensitive. The cost is actually more expensive for low numbers, but about equivalent to ONT if you have more than 15 samples. But one of the things it does do is it preserves the transcriptomics. And one of the things we are interested in is actually using the same sample to detect host biomarkers so that we can have a more precision medicine approach. And of course, the host depletion in the Nanopore method doesn't allow that. So having stood up the respiratory metagenomics and found it so useful and good, we suddenly thought to ourselves, well, let's have a look and see whether we can do Nanopore for sterile sites. So to do this, we mocked up some clinical samples. We chose 6 different viral families, DNA and RNA. We did dilutions from low levels up to 10,000 copies per mil. We mocked up the fact that we generally are testing high biomass samples, or we want to be able to test high biomass samples, and that also that the transcriptome was retained. And we looked at 3 methods. We used our untargeted Illumina metagenomic service. We used an untargeted Nanopore metagenomic approach, and we also looked at capture probe enrichment, because we know that from other work that we've done that the sensitivity of detection of pathogens is greater if you can use enrichment. So this is the result, and this is work that we've published on the sensitivity of the standard ONT versus the Illumina platforms. And you can see here in green is the ONT. Here are the base pairs detected. So this is the log. So getting up to quite respectable levels here. And these are the dilutions from 1 to 4 log, or the most dilute to the least dilute along the bottom here. And what you can see here is that the standard service here is pretty good, but it does miss some low-level stuff, as you can see here. It's in red. Nanopore is less successful with this sort of sample, with this high biomass sample at the low levels. But the targeted enrichment and metagenomics is stupendous. And we're getting here down to levels of detection that are approaching those of PCR. The targeted methods actually are quicker than the usual method that we use. And here is this is the sort of process of our normal untargeted Illumina method. And you can see here that adding in the target enrichment means we don't have to do so much sequencing. So that was a benefit. But we thought to ourselves, well, what about if we could do capture on the ONT? Could we make that as sensitive and faster? So there is already a protocol out there that looks at targeted nanopore sequencing, and that involves a ligation step where you ligate the sequencing primers to the capture library primers in order to allow the sequencing, the ONT sequencing. And that conversion step is about 2 to 3 hours, depending on the number of samples. It's rather expensive, and it's very labor-intensive. The other protocols, or certainly the existing nanopore protocol, is extremely efficient. It would report out, if you were to report at 1 hour, at the end of the second day. So before you go home the second day, and then a final report at midday on the day 3. However, that really is not giving us as much advantage as compared to our Illumina method. So in order to deal with that, Oscar Torres in my group worked out a workaround, which is rather intriguing and simple, but very effective. And what he has done is he's designed a primer that has both the capture library target, which is actually an Illumina target, and linked to it is the ONT sequencing target, which then enables that to be a PCR, simple PCR to be done, and that can then be incorporated directly into the ONT sequencing protocol. And what is the result of that? Well, first of all, if you look at the enrichment, here we have the original nanopore. You can see, again, it's not hugely sensitive. When you use this capture enrichment, you're getting the same sensitivity as the capture enriched short read sequencing. So massive increase, 10 to 100 log increase in sensitivity, detecting even the lowest level of viruses by this method. And this is just to remind you that this method is way more sensitive than even our current accredited pipeline. So really a very interesting outcome. How is it doing in terms of turnaround? Well, this is the effect of getting rid of the conversion here. You make the whole workflow much shorter, so you can report out after 1 hour of sequencing at 3 o'clock or 2 o'clock in the afternoon of the second day. And then you can also do a second report if you want to at 4 hours just before you go off for the night. And then the next day you have the final report with the full genomes and the greater sensitivity. What does that give us? Well, if you report out at 1 hour, then you're getting all of the high copy number pathogens. You're getting quite a lot of the medium copy number, and some of the low copy number pathogens are detected. If you do it at 4 hours, you get all the high copy number and all the medium copy number, and about 50% of the pathogens at low copy number are detected. And then the next day you get the majority of the low copy number pathogens. And there's some work to be done here, but that is at the moment a pretty good outcome. So it doesn't stop there, because we have been doing some work as well on looking to shorten all the other aspects of the pipeline. And we have tinkered with the extraction, changed the extraction protocol, changed the hybridization. We can get the hybridization down to actually extremely short times now with very good results. And that allows us to actually report out the same day this highly sensitive metagenomic pipeline at around between 4 and 6 o'clock in the afternoon, with the final result coming out with all the sort of full genomes and the low-level sensitivity the next morning or the next day at midday. So I hope I've shown you that this is a rapid method, that respiratory metagenomics is faster than the standard microbiology for identifying respiratory infections with similar performance. It has a proven impact on diagnosis, on management, and we still need to do the full cost-benefit analysis, which I know Guy's and St Thomas's are leading. The pipeline was developed at GST, and it transferred extremely well to a second site, and I have no doubt it will transfer to others just as well. It can be customized to local needs. It's very robust and reproducible. And we've also shown that actually by adding in the targeted nanopore sequencing, that we can now make metagenomics up to the levels, I think we're approaching the levels of PCR. We haven't yet formally tested that, but that's on the horizon, which will enable us to use the nanopore sequencing, the rapid turnaround, where both detection and exclusion of pathogens is critical. That's sterile sites. The very fastest version of this is simple, cheap, and could be read out the same day. And I think that begins to rival, we're beginning to approach the possibility that this could actually be considered instead of PCR. We are able to preserve the host transcripts for a precision medicine approach, so that's also extremely useful, and we're looking at that. And this method is not just confined to metagenomics. In fact, it can be used for anything. You can use it for, whole genome sequencing of any pathogen, host exome sequencing, pharmacogenomics. It's a rapid method that seems to be sensitive enough to address all of those uses. So it just remains for me to thank the people who did the work. The new developments were done by Oscar Torres in Montague and Sarah Buddle in my lab. Robbie Hammond, Angelica Kopek, and Julianne Brown led the respiratory metagenomics. Rachel Williams, Lisa Forrest, and Liz Marina Martin are the people in the UCL Genomics facility who gave us help. And our funders were the NIHR and NHS England. Thank you very much.